Greetings. I'm Jim Tagliaferri from Alivia Analytics. Welcome to the Trends in Technology Impacting Payment Accuracy. I want to first introduce our moderator, Dr. Michael Taylor. He is the CEO of Alivia Analytics. A little bit about Mike. He ran a successful family practice before 20 years of experience in payment integrity technology. This included being CEO of Medicaid Audit and Review that was acquired by Multiplan in 2015. I'm sure you'll enjoy today's session, and I turn it over to Mike.
Thank you, Jim. Hello, everybody. Good to see you. I'm glad we have a good audience this late in the day. You should give yourselves a hand. You are the diehards. And this is the last session before it's fun time. So I truly hope it's been a productive meetings, this morning for everyone, and that you found them very informational. And I have the privilege of presenting what I think is a really great panel for you tonight. And so with that, let me dig in here. And our subject, Trends and Technology Impacting Payment Accuracy in 2023. And so we're going to talk about a broad range of technological challenges and other trends that our panel here thinks will be of interest to you. And so we're going to go through panelist introductions. I'll briefly show the discussion format. And then we'll go through the different points in the state of the industry and have time for a Q&A at the end. If I could ask our assistant in the back if we'll be starting the clock. And I'll give you panelists a sense of how much time you have left as we go through. Some of the points that we're going to concentrate today: challenges with data, structured, unstructured, big data, new and different data sources that you may be struggling with or may view as opportunities to get better results in your payment accuracy challenges. The trend of movement of payment integrity and payment accuracy from post-payment to prepayment, but maybe also the need for those two types of payment accuracy to speak with each other and for a feedback loop. Outsourcing versus insourcing, or the new term where we often hear of intelligent outsourcing or SmartSourcing. We have an AI expert here today, and we'll be talking more about AI challenges and opportunities. And I hope an issue that's of great importance to everyone here, it certainly is to me, and that is security, where the risks and the penalties and the challenges are higher than ever in today's healthcare environment. And so our panel, first let me introduce Dale Carr. Dale probably doesn't need an introduction in this audience. He is the director of Missouri Medicaid Audit and Compliance, MMAC. And MMAC is responsible for administering and managing Medicaid audit and compliance initiatives in the Medicaid program in that state. Dale is an absolute wonderful resource. He's taught me a lot. I encourage any of you who don't know him and haven't had the opportunity to meet him over this conference to please introduce yourself. He is always happy to share his knowledge of payment integrity and fraud, waste, and abuse. We also have in the middle of our panel here Dr. Steve Goldberg, and I'm very pleased to have Steve as our Chief Medical Officer at Alivia Analytics, where he recently came after a multi-year stint as the Chief Clinical Officer of Quest Diagnostics. Steve has won just about every award that doctors could win except for the Nobel Prize. He has won the C. Everett Koop Award for National Best Practices in Managing Healthcare. He was named in 2020 in modern healthcare as one of the 100 most influential people in healthcare during the pandemic. What number were you, Steve? 39, okay. Maybe you could try to move up next time. And Steve has been a chief medical officer and medical director at numerous plans. I won't go through them, but he has service in government-funded healthcare, in private healthcare, a luminary in the field that I'm very, very proud to have him with us today. And last but certainly not least, Paradise Valley resident and local gentleman, Scott White, who is an IT expert. He has decades of experience in IT security, leading both provider organizations, security organizations. He has decades of experience in consulting, servicing both commercial, private, and government organizations. And most recently, has been appointed a partner at Health Enterprise Partners, where he's an operational partner and an expert to their portfolio companies. I want to thank each of you for being here today and for your expertise. We've got great attendance, and let's have a great panel. With that, let me put my one contribution in. I hope this doesn't insult anyone, but I really became aware of the Medicaid environment back in about the year 2000. And from my perspective, things moved kind of slow. The technology was oftentimes out of date. And I was thinking, compared to today's smart AI, the technology wasn't all that smart back then. And so I likened it to this Brontosaurus here, or Brachiosaurus, and slow-moving plant eater, takes its time, gets the job done. Maybe a little, overloaded. Definitely don't have any excess resources today, I'll tell you that. But things have changed a lot. And so when I asked AI to show me what's a modern depiction of what the Medicaid environment is like, it generated this. Yes, it's a different animal today. Budgets are tight, everything moves fast, and if you're not ahead of the curve, you're gonna probably get eaten by a dinosaur that looks like this. And because this is so important, it's really the healthcare of some of the most vulnerable people in our society. We all have a duty to be stewards of that and to preserve that. And so I would submit to you that we have to be ready to deal with the realities of today in a much more fast-moving, aggressive environment where there's no room for mistakes. And with that, let's dig in. And I'd like to put the first question to you, Dale. Let's talk about data challenges. I know today we have new data sources that states and organizations are using for payment integrity, payment accuracy, and a multitude of other uses. Structured data, unstructured data. What does that mean to you? How are you adapting? And what advice can you give the audience?
Well, thank you. That's a great place to start here. So, I really felt I've been with Missouri as the director for about the last 7 years. I was provider enrollment manager before that, and did some other things before that in the state. But I felt that we were behind the power curve. But I do think that the solution that we have. Thank you. Can everybody hear me? Okay. I'm sorry about that. I do think that the solution that we have now, that it has gotten us where I'm very comfortable. I feel like we are at the cutting edge right now. Our problems are not new, but we have much better tools right now to be able to address our problems. The new solutions that we're looking at and that we have, they are extremely flexible, and that works to our benefit. We are pulling a lot of other data besides our Missouri Medicaid claims. A standard claim, if we do our full-blown layout, where we take the claims data out of our Medicaid system and we put it into an Excel spreadsheet, and you go all across the columns, there's like 153 different columns just for a single claim. But above and beyond that, We're also pulling in other data sources now into our integrity solution, things like our electronic visit verification data and some other areas. We're looking at pulling in all of our financial data does not go to our it is not part of our normal VIN layout that goes to the vendors, and so being able to insert that financial data is going to allow us to be able to do more in that area. I think that we've really picked up our game in the last couple of years in the area as far as integrating our encounter data. I know that a lot of states struggle with that if they do managed care. I realize there's some still out there that do not do managed care, but most of the states do either all in or in some percentage. About 5 years ago in Missouri, we went from 30% to about 75% managed care. And so being able to pull that enhanced encounter data in and being able to work that, getting a much better picture of what our Medicaid exposure looks like in the state. So we have 3 contracted MCOs in the state of Missouri, and so if we have an auditor or an investigator starting to look at something, or if we're analyzing something and they've popped out as an outlier, then we're off the dashboard. You can see, okay, their exposure fee for service, and with Plan A, Plan B, and Plan C. So that has helped us out a lot. We can also we've worked with our Unified Program Integrity contractor, the UPIC, because they can also help us with the Medicare data for that provider, and again, give us an even more complete idea of what's going on with that provider. And when you start talking about like impossible days, right, counselors that are billing too much, and you can look at that fee for service, you can look at all those 3 plans, and then we go to other sources within the state. We go to our children's treatment services through Children's Division, or some other things that don't show up in our MMIS system, and you see these same people popping up, and pretty soon they're just in impossible situations. The number of hours per day, the number of days that they work consecutively, the number of weekends that they work consecutively, such like that. I think that the technology is also, I mean, obviously we've seen increased ROI as far as recoveries. We're also seeing increased cost avoidance, right? So we identify through our analytics and through our audits and through our investigations, we identify weaknesses in the system, but we're able to put new prepayment edits in place, or we'll put people on prepayment review, and our cost avoidance has been trending up significantly over the last couple of years in our state. The folks seeing what these new tools are able to do for us, it's been a lot easier for us to go to our legislature, to the governor's office and such like that, and put in new budget requests. We were able to get 10 additional full-time staff this next year, five auditors, 4 new enrollment staff, and an additional investigative position. I have 81 people now, so 10 more people is 91. That's more than a 10% increase in staffing, but we're nowhere near the point of diminishing returns. So I will be back there next year and be asking for more, because we're just it's leading to additional things for us. A couple big things with the new solutions that we're using, the speed of the reporting. The tools are just so much easier to use than the tools we've used in the past. I don't know what all system everybody's using, but when I first started as investigator or whatever, and if I wanted to run my own report and I wanted to set up the parameters of the report, it was kind of like typing in formulas for an Excel spreadsheet or something like that. You had to have some knowledge with some equals and some things in between or whatever. And we don't have to do that with the new solutions. The auditors and the investigators absolutely love it, because they can go in. If there's not a template already in there for them to use, they can put together a report of what they need very quickly, and they don't have to wait for a data analyst or somebody to be available to run that report for them. And they can drill all the way down to the claims data for whatever it is they're looking for without doing any additional reports. And then finally, I think that in this area, the time savings that we've, just by automating processes, we had my provider review manager back there, Darla, and I look at her and I think, hey, we had a process for, like, if we want to do a hospice auditing, it started with the state Medicare agency, and they had to do some manual processes because the amount changes, right? As it gets closer to the date of death, they get a little bit more money, and so they have to go back after the date of death, and they have to make some adjustments or whatever, and so there was a very manual process with the state Medicaid agency, and then it would come over to Darla's team, and the nurses would have to do a very manual process, and there was some adding and subtracting going on, and there was errors in that just by the nature of doing it manually. And so with the new solution that we have, we've been able to completely automate that process, and the time savings are just tremendous on that. We've been able to take something that may have taken 3 days and get it down to maybe an hour process. And so that just frees up your investigative and your auditor resources tremendously. So I think we're just, again, that's a long answer, but I think that we are really taking advantage of the new technology to make ourselves leaner and meaner.
Well, thank you, Dale. Great insights. And it's clear to me by mastering your technology and taking control of your data, you've unlocked a lot of value, and you've done some great things. That can be difficult from a technological perspective. I remember decades ago, we came out with data warehouses to house structured data and make it available. More recently, you hear terms like data hub, which communicates with various other systems inside your organization. And maybe my favorite, the data lake, which is supposed to house unstructured data and make it available for modern AI technologies. But from what I've seen, your data lake is at risk of becoming a data swamp if it's not properly curated. And maybe, Scott, you could talk about this, the technological challenges that underpin some of the advances that Dale has made. What are folks involved with here?
Well, Mike, I think you've hit on a really important point. I think most of us have been fishing in the swamp, or we've seen the swamp. We've seen that environment of really dirty data, or the uncertainty of knowing whether we're dealing with some clean water or some swampy water. And I think there's a whole specialty of data quality and understanding how to build in that data quality from the beginning, and then recognize when there are issues and correcting that data quality. That said, I think it's critically important in these cases to have a guide through the swamp, right? To have someone who understands the context of the data, the workflow of Medicaid claims processing systems. What is that data? How are the users using it? The data flow, even from the source of the claims into your systems, I think is critically important. To have someone who knows that context and can tease out the elements of data quality and prevent that poor data quality from really preventing the good results that Dale has experienced, the reductions in labor and higher recovery.
Thank you. Shifting gears a little bit onto the trend of movement from post-payment, pay and chase, to prepayment. Steve, as a physician, you're always thinking of quality of care, value. What does this trend mean to you?
Going after as Warren Buffett described it, the tapeworm, right? So just to give us all the context of fraud, waste, and abuse in the U.S., each person in the U.S. is contributing about $13,000 a year to the cost of health care. It is $4.2 trillion, and a recent Health Affairs article estimates it's going to rise to $7.1 trillion by 2031. Healthcare is inflationary by structure, and fraud, waste, and abuse, based on a number of calculations, Institute for Healthcare Improvement, an article in JAMA 2019, estimates that fraud, waste, and abuse is about 25% of the spend. Do those numbers seem familiar with folks? So that is an enormous burden. Half of people who have a cancer experience can confront a personal bankruptcy. So the work that each of you do every day is foundational to us trying to improve the U.S. healthcare system. And as Mike referenced, I think all of us have a goal, have a vision, where if we think about healthcare quality, going up and down, cost this way, what we want is for every person to get highest quality at best value. And doing work on fraud, waste, and abuse is critical to that. So how do we do it better and better and better? Well, in the work that I have done in health plans in large Fortune 500 companies, I think about quality and spend across 9 different cost categories: inpatient, outpatient, ambulatory, lab, ER. And what we see is that for a given episode of care, back surgery, sinusitis, there's a wide variation in how people are approached. And when we look at cost, there's a wide variation in the bill. Is that consistent with what everybody sees? So what I think we all want to drive is a narrowing of that occurrence, right? So for a given episode of care, wherever you are, you're getting evidence-based practice. And for a given cost, wherever you are, you're getting a reasonable cost. So we have a lot of work to do. I've been involved in retrospective reviews for north of 20 years. My favorite ones were looking at outlier hospital claims and going line by line by line. Oh my gosh, $1,000 for Valium. Oh my gosh, $600 for a lab test. So retrospective review can be helpful. And I look at multiple state findings, I look at OIG findings, I look at RAC audits, and sadly what happens is bad things happen, people catch it, and then we socialize the opportunity. 2020, I think a $1.2 billion telehealth episode in aggregate of fraud. So retrospective is good, but the challenge, I think, in order to really impact the quality of care, narrow that variance, get people the right care, is we got to engage as early as possible. By that I mean post-adjudication, pre-claims payment. And I think if we do that, we can give prompt feedback to hospitals and physicians and other organizations to adjust their practice, let them know we're watching, and let them know we're engaged so that we're not, frankly, pay and chasing, that we're reinforcing habits in that transaction process.
Yeah. Thanks, Steve. And Dale, we've spoken in the past about moving from post-payment to prepayment, about always the need for a feedback loop, because some information just doesn't become available until some point after the payment is made. Do you have any follow-up comment just from your state perspective?
Yeah, I think that, you know, again, talking over the years and having the opportunity to go to a lot of conferences and talk to a lot of different types of providers, you know, you cannot be 100% prepay or 100% post-pay. You know, I've talked to providers, you know, commercial players and managed care organizations and stuff, and say, we don't do a lot of FWA because we have such outstanding prepayment audits in place that, you know, nothing really kind of gets through or whatever. And that's not the case necessarily, but you also cannot be, you know, 100% you know, post-payment review either. And so you know, I think that it's trying to find that sweet spot depending on your state and, you know, your situation there, to where you're balancing it out. And, you know, we kind of talked a little bit, but you know, and we're all pretty much state agencies in here. I see many of the states here represented, and I know there's some federal folks here, but unlike the private sector, they can implement changes very, very quickly. If there's something that's identified as a weakness, they can get that in there. But in the state systems, getting that systems work in place to get new prepayment edits in there, or if it's something that's going against an existing regulation or statute, and we have to go in and get those things changed, it takes time. And so we're trying to make that happen as quickly as we can. But yeah.
So take advantage of the new, smarter prepayment technologies, but don't give up on post-pay.
Right, and I would add just an N of one, that in my work in the Fortune 500 space over the past 7 years, at a certain dollar threshold across 9 cost categories, I gave some examples, at a certain dollar, let's say about 100,000.
Use your microphone, Steve.
At a dollar threshold of, say, 100,000, the rates of coding error plus minus turbocharging, in my experience, was 100%. And there's likely a point at which that cleans up as the dollar amount goes lower. So prepayment, I think longitudinally is really the way to go.
Great point. Can't emphasize enough, for those high dollar bills, they deserve all the attention that you can give to them. Dale, you touched on this, and I was intrigued a few moments ago about the insourcing and outsourcing. I know in your state you've had a tremendous amount of success generating leads, following up on those leads. Could you tell us more how you have approached outsourcing and insourcing?
I'd be happy to. I really am proud of what we're doing, within the state of Missouri in this area. We're not the biggest state, and we're not the smallest state. We have about 1.5 million covered lives in the Medicaid program. We have 71,000 providers. But I do think that we are being fairly aggressive with regards to our audits and our investigations, and we're always looking for opportunity. I'm always looking to expand our bandwidth, right? When we were doing the implementation of your solution, during the configuration, the validation, UAT phases, and we gave you 3 years worth of historical data, 36 months preceding the the period there. We identified 15,000 actionable leads during that process, and that was at a threshold of $5,000. And then we've been in operations now for about 18 months, and so it's working out to about 5,000 new actionable leads per year. So we want to be able to work as many of those as we can. Obviously, we're looking at the very high dollar ones. We're looking at the straight out fraud, right? I mean, if you can look at something and you can tell that on its face it's absolutely fraud, but still, we would like to go as deep as we can into those actionable leads. And so, again, I'm fortunate to have a great team of investigators. We've got Darla's group back there, our provider review group. We just added 5 more auditors that we're going to this year, so probably about 35 people in that unit. But we're looking for new resources all the time. So we have our Unified Program Integrity Contractor for our Midwest region there. They are great partners for us. They're constantly doing their own data work, and I know that CMS has some priorities that they want them to kind of work on, and they're taking a better look at managed care and stuff. But we've also been able to take some of our best actionable leads and present them to them. They get a whole write-up, and they take a look at it, and they open it up, and they run with it. And we're doing kind of a proof of concept around that. So we're taking advantage of their help. We obviously farm out if it's straight out fraud. We like to get it to the OIG or the FBI as quickly as we can, our Medicaid Fraud Control Unit, to see whether or not they might be interested in it. If not, we'll go ahead and run with it ourselves. Some of our best cases have been their declinations there because, and I don't know why they declined it because it was an outstanding case, but we took it and we run with it, and we've gotten some outstanding results, and so we've sent it back to them now, several months later with it, packaged up and ready to go. But we went 6 years without a recovery audit contractor. I know that there's a lot of states that have waivers from recovery audit contractors, but we had an opportunity this last year. Our third-party liability contract was coming up for renewal, and so we added some language into that, and we've got our third-party liability contractor agreeing to be our RAC going for the next couple of years. So I'm just trying to get the signatures on that because I'm really running and ready to go on that. I know that they're very capable in the program integrity area, and I think that we're going to go through and pick out a bunch of leads that are within their wheelhouse, so to speak, and the things that they could do the best on. So we have the RAC, we have the UPIC. We may open up a special project on something if it looks like it's suitable to do it that way. We also, I mentioned before, but when we're analyzing the outlier and we're looking at the exposure and stuff, we've been sending a lot of leads to our 3 SIUs of our 3 plans there, and encouraging them to work it. And we've done the deconfliction. We've made sure that nobody else is working on it, and so it's pretty much like, hey, you guys are getting hit pretty hard on this, and nobody else is going to work it right now. Go ahead and run with it. Take it as far as you can. And so, kind of, I like military science. It's that force multiplier, right? We've expanded our bandwidth for being able to work as many of those good leads as we could.
Thank you, Dale. Great answer. Appreciate it. Steve, from your clinical perspective, let's give the audience some tips here. What's the most high-tech, complicated clinical fraud, waste, abuse schemes that you're seeing these days that folks should pay attention to and be aware of?
Genetic testing. So let me try to set this up. There are about 175,000 genetic tests in the marketplace. There are about 10 to 20 new tests a day. There are different categories of testing, right? So there's newborn testing, there's pregnancy-associated testing, there's testing related to cancer, there's testing related to genetics for medications, there's testing related to certain conditions for which someone might be a candidate for cell or gene therapy, there's emerging testing for dementia, et cetera, so lots of different categories. There's an AMA CPT committee that sets up general categories for how you organize codes. And then there's different organizations depending on payer about how they structure coverage policies, what will be reimbursement or not. So it's the fiscal intermediaries, primarily Palmetto is the lead for Medicare, and then the commercial plans have their own, and Medicaid coverage policies also exist. And some entities don't provide genetic coverage, but that's kind of the overview of the coverage policy. Despite guidance, there can be predatory activity on how coding is submitted. The order of the coding, the bundling of the coding, or the, frankly, unbundling of the coding, and also trying to slide in there to extract reimbursement for genetic tests that don't provide any clinical impact, right? So, for example, if you're unfortunate to have a breast cancer experience, the standard of care now is to get both your genetics and the tumor analyzed because it can impact the course of chemotherapy. Yet there are genetic mutations in cancer discovered all the time. A majority of them might not have clinical impact, yet predatory labs know that and try to get payers to pay for them. It's incredibly difficult, incredibly unorganized. Health plans, through informal conversations I've had with genetic policy leaders, spend about $1 billion a year just to do pre-auth process, $1 billion. But there aren't enough genetic counselors and genetic specialists to be able to run that pre-auth process, so there's wide variability in what they do. And then we're all following the news about post-event fraud findings. Medicare and genetic testing. I think there was a $400 million occurrence in the past 3 or 4 years. I see folks nodding. It is a huge problem. Now, the good side about personalized medicine is that there's the hope that your genetics can really optimize disease control and risk control and optimal therapy. So we want the technology to proceed, but the ability to put appropriate controls around it is very, very difficult. And it's an area that I continually study. And frankly, we're working with partners that have expertise on the pre-auth area and have ways to help us organize what appropriate submission of information ought to look at, and help us identify when that information has not been submitted in a propitious way so that it can be flagged. But I see that as something that keeps me up at night.
Absolutely. From my own experience researching this, unless the guidance you're using has been put together by an organization that has at least 50 researchers who are experts, who are keeping it up to date, it will fall behind because the field changes so quickly and the fraud schemes are constant and changing. And you know, there's real harm to a patient when you do a genetic test for which there is no clinical benefit, and you saddle that person with a potential lifetime of worry now that they think that, you know, they have a mutation that could contribute to a life-threatening or an event that may shorten their life, and yet there's nothing we can do about it. That requires detailed ethical planning and consultation, not the kind that just a lab that's sending these things out takes the time to do. So great point, Steve. I appreciate that, that subject. Scott, to you, maybe we'll ask you to comment on a trend that everyone in the room is hearing about probably every day. AI, artificial intelligence. What does it mean to us in payment integrity? And can you break it down a little for us?
Yeah, absolutely. So I'll start with a confession. I have not seen either of the Barbenheimer movies this summer. Yeah, I've not seen those. And I think that's actually, it's interesting because we should be out there seeing the movies that we can right now, because as you know, there's a writer's strike going on. What's at the core of the writer's strike? Exactly. The script writers are afraid of ChatGPT. They are afraid that large language model, artificial intelligence systems can do what they do, can take away their jobs. And I'm here to share within just a few minutes a way for you to answer that question. If your friend or your spouse asks, you know, you're the head of payment integrity, is ChatGPT going to replace you and your team? And you'll have a quick, concise answer to that question. So, first of all, what is AI? And what can it do? What can it not do? And what are the takeaways for us? What is AI? Artificial intelligence is the broad, overreaching term. And it's really what it says. It's allowing a machine, a computer in this case, to take on human intelligence types of tasks. So things that appear like reasoning and problem solving. But it's artificial, right? It's a computer, it's not a human. Machine learning is the branch beneath that is most commonly applied. And in that case, it uses very, very large sets of data, and then you run it through models, and it can rerun, and you can tune those models so that it can recognize patterns. And that's been around for some years. What are the large language models, also known as generative AI, and that is what ChatGPT is. GPT stands for generative pre-trained. So the generative means it's what it does. It generates text back to you. If you've used it, you can go to Microsoft Bing, which is their browser, And right over the side, it'll have ChatGPT working. It's Bing, but it's ChatGPT version 4 that is working. You can do that on your phone, your tablet. Don't do it on your work computer. We'll get to that in a moment. That solution is also Google Bard. ChatGPT and Microsoft Bing are all kind of related large language model systems. And it generates text, and it does that by that pre-training. And the way ChatGPT works is it has more or less vacuumed up all of Wikipedia and 500 million books and all of the blog posts and scientific papers and documentation of systems and things, coding, instructions, all been analyzed, and it's all turned into math. It's all, every word in the English language, 50,000 is a number, and every relationship between words and how they're used are numbers, and it's complex matrix mathematical equations that do this. It takes a lot of computing to run that. And all it does is you put in a prompt, it effectively reads that prompt, and then it's going to predict, it's going to start with a word back, and it's going to, one word at a time, it's going to run hundreds of thousands or millions of calculations to think what would be the next best word. You know, I fed my, and it's going to choose, you know, dog, cat, or car, right? And mathematically, dog or cat is a better word to put there, and it does that over and over again and can compose a whole sentence, a paragraph, or paper, I think, as you may have seen. So that's ChatGPT. What can it do? The narrow AI, so think about those machine learning models, that training can be very specific, and you can train it on things like structured data that comes in from a claim, and you can train massive volumes of claims, and it can start to recognize over time what are errors or fraud or waste or abuse, and it can flag those, and you can have a much, much higher false positive rate using tools like that. And that's, it's not easy, and it takes a lot of experience, but you can use those models and tune them to accomplish that. What the large language models can be used for, what they do is they can read and they can write. So you think about applications like potentially drafting a letter to a provider. You know, you could draft a concept letter to a provider. I wouldn't want the thing to send it out for me. You could use a ChatGPT type of tool for a chatbot. If somebody wants help for a subject, and you probably have seen that in some of your, where you'll enter some text and the bot will respond back. It could have read a whole manual or a whole set of policies, and it can quote, understand. It will know how to respond based upon those that input. Microsoft is coming out very shortly with a way for Bing to help with office automation. So you can think about getting a bunch of numbers, it can put those into Excel and then put those into a PowerPoint. You know, it can weave the office tools together. That would be nice. It would save you a lot of work and time. So there's lots of positive potential applications for ChatGPT. What can it not do? Well, for the large, for the narrow models, it can't do something it wasn't trained to do, right? That actually is a benefit, because think about the data that we're dealing with is complex, it is sensitive, we're dealing in highly regulated environments. We want, and we don't want the model kind of inventing things on its own. We want it to follow the rules that we have validated. And the narrow models are going to be more restrictive. The large language models are newer and absolutely have many more cautions. So the large language models are oftentimes forbidden, I'm sure, by many of the organizations that you come from, both certainly state, federal, and commercial organizations are saying you cannot use that tool in a work environment. It's only recent, for instance, that ChatGPT came out with a HIPAA business associate agreement that you could engage in, you know, legally. So that's, of course, a huge caution. It's actually not legal for us as stewards of healthcare data to have a business partner see and manipulate the data without a business associate agreement. That's just an example. The large language models also are not good at precise analysis. Well, that's much of your work. It's the fractions, it's the precise analysis that we've heard about is what we need, and the large language models today cannot do that. They're also prone to, this is kind of a funny term, hallucination. So this gets to the garbage in, garbage out, a little bit of the data swamp comment. You think about these tools have sucked up the whole internet. Well, we all know there's a bunch of junk out there, and these tools can come back with an answer that actually seems correct, sounds correct, but is not at all. So lots of cautions there with what it can't do. So what is the takeaway for us? You know, we, as payment integrity people, should be naturally, I would think, critical, skeptical, cautious people. That's part of the profession. We're looking, in some cases, at errors and bad actors. And so this is a time to, I think, be cautious about overhyped new technology, okay? I also think it's a time to take advantage of the models that work. I think Dale gave some great example. How exciting is that for us who want to prevent the waste that is out there? We want to provide additional access to healthcare. That's what I'm passionate about. And if we can save money that's being wasted on bad claims and provide care to people who need it, that's a good thing. So use the tool, the right tool in the right way, which I think is another point is finding people who can distinguish which tool should be used where and develop those, you know, partnerships or find the trusted people who can explain what they're doing in plain English. So you should be able, as an operations professional, not a computer scientist, you should be able to have some understanding of what this tool is doing. And if you don't, then to me that's a red flag. The final guidance I would give was that you should watch out for security. And I gave the HIPAA example as one, and I think this is one of the reasons why some of the security executives have banned the use of these tools is ChatGPT would just be an example. It's going out across the whole internet. I mean, that's kind of the way it was designed. And you want to use tools that are focused on the specific sets of data and that you know that you have confidence that they're not going to wander and go astray. So, back to the answer. If your friend asks you, are you going to be replaced by ChatGPT? The answer is no, you are not. There could be times in the future where ChatGPT can actually augment the AI, the machine learning. You can picture having your large language model do some analysis or pre-processing on text. That could be very good if you have a voluminous medical records or something that needs to be interpreted, new regulations. You can have that tool pre-process that, turn that into numbers that can be used by a more constrained artificial intelligence system. So, we good to go? Ready to answer? All right.
Thank you, Scott. And I'd like to thank the audience. Our panel has come to a close. I'd like to thank the panel members. Maybe we could give them a quick hand. As this is the final session, if you do have any questions, comments, or want to meet any panel members, please feel free to engage them now or afterwards. And for a copy of the recorded session or continued conversations, please look to the back and you'll see Lucas Gallardo. He would be happy to arrange that for you. Thank you.